And thank you all of you for joining us today. I'm Scott Benson. I'm a child and adolescent psychiatrist. I practice in Pensacola, Florida. Prior to my training in psychiatry and child psychiatry, I completed training in pediatrics, and in that situation, in that role, learned to appreciate the prevalence of psychiatric conditions, as well as learning the difficulties in getting access to quality care in the community. And when we did get access, it was often difficult to maintain contact and get collaboration. So I'm excited that we're able to bring this conference today and try to take some steps to address some of these problems. Our presenters today, Dr. Castellanos is Florida International University, and their head of their Department of Pediatrics, Dr. Haravu and Anna Baznik. Dr. Kasha is a pediatrician. Lokesh is a pediatrician working in Pasco County. He's going to talk about some of his experience getting collaboration in treatment for children with ADHD, disruptive behavior problems in his community. Ms. Baznik is going to talk about some new innovations in telepsychiatry and what will be available in Florida, may be available to practitioners as an additional support for the care that we're providing to these children. Let me introduce Dr. Castellanos. I'll just turn it over to you, Dan, and let you just provide a little bit of introduction about yourself.
Good afternoon. Thanks for the opportunity. As Dr. Benson mentioned, I am an Assistant Dean for Graduate Medical Education here at Florida International University, as well as the Chair of the Department of Psychiatry and Behavioral Health, and I appreciate the opportunity to be with you. Today, we're going to start this segment of the presentation with a journey into reviewing some of the more common psychiatric disorders that present in children and adolescents, with a very particular focus on ADHD, which you'll see the reason why in a second. We will address how to screen and diagnose ADHD. We are probably not going to review disruptive behavior disorders in youth, which include oppositional defiant disorder and conduct disorder, because of some of the complexities and the time limitations. Then we will move on to review the interventions for youngsters with ADHD, attention deficit hyperactivity disorder, with a particular focus on medications, evidence-based use of medications for this population. True or false? Depression is the most common psychiatric disorder found in children? Actually, it's false. So when one looks at the epidemiology of childhood behavioral health disorders, ADHD is in aggregate the most common disorder seen in children and adolescents, followed by these behavioral disorders that I just mentioned, the oppositional defiant disorder and conduct disorder. We do know that there's different expressions of behavioral disorders depending on the age group, so that we know that certain disorders have onset in pre-adolescent or childhood, and those include things like ADHD, as we just mentioned, autism spectrum disorder, intellectual disability, and certain types of fear-based anxiety disorders, such as separation anxiety disorder. When we look at adolescents, we also recognize that certain disorders have their onset in adolescence and are not seen as often or as frequently in pre-adolescent children. And those include presentations of major depressive disorder, substance use disorders, eating disorders, etc. And so taken in aggregate, since ADHD is the most common disorder seen in children, that's where we're going to proceed with today as far as our review. We're going to start with this first vignette, and I'll go ahead and read it, even though it's there in front of you on the screen. The parents of Tommy, a 9-year-old fourth grader, believe that he should be doing better in school, given how bright he seems, and the fact that he has received mostly A's throughout his schooling up until 2nd grade. He requires frequent prompting to complete his homework. He forgets to hand in his papers on time. His book bag is always a mess, and he makes careless mistakes on examinations. The parents also report significant difficulties with time management, planning, and organization. Tommy is very forgetful and often loses things and is easily distracted. He has no history of restlessness or impulsivity, and Tommy is generally well liked by his peers. During the evaluation, during the interview of Tommy, he is shy, polite, and cooperative. He reports a long history of failing to give close attention to details, difficulties with sustaining attention while in class or performing his homework, and problems in keeping up when he's required to write things down in class. Tommy does admit to feeling upset because, quote, my mom is always yelling at me. His mood is generally happy when playing with friends and in his after-school activities. Psychological testing was available and it was completed 4 weeks prior to your visit, and it displayed that Tommy is a very bright young man, as you could see, with a verbal IQ of 125 and a full scale of IQ of 123, but with relatively lower working memory indexes and processing speed indexes. And weaknesses in executive functions were also noted. So the most likely DSM-5 diagnosis, or take your pick, ICD-10 diagnosis, would be, needless to say, attention deficit hyperactivity disorder, but the predominantly inattentive presentation. So as you saw, some of the detailed history that was revealed there, that Tommy presents some of the difficulties with executive functions. Executive functions involves abilities to perform activities that we all have, but that develop during our formative years, that include the ability to plan, organize, prioritize, develop your working memory. Working memory is basically the ability to keep something in your memory while you're performing another mental task. So that's a little bit different from short-term memory. The ability to activate mentally, the ability to shift, the ability to initiate. An example is if Tommy's watching TV, he has to turn off the TV. He's got to get going mentally. He's got to shift out of TV mode into work mode, and he's got to go start his homework. Needless to say, the opposite of that is procrastination. So part of that assessment involves getting a detailed history of those behaviors and seeing how they've been developing and whether they've been exhibiting themselves across situationally in cross situations, not just at home, not just at school, etc. In addition to, as part of your assessment, as you all know, you want to treat any coexisting or comorbid disorders, including any learning disabilities or learning disorders, as they are, our nomenclature now refers to. As I just mentioned a couple of seconds ago, one of our criteria for diagnosis of most of our childhood disorders is that there must be cross-situational expression of the behaviors. That is, when a behavior occurs exclusively in one domain, gee, it only occurs in the home, it only occurs at home, etc., it has one rethink about the disorder and possibly conceptualize it differently. We always strongly recommend the use of standardized rating scales that will be helpful in assisting make the diagnosis, but also to obtain the baseline assessment of the severity of the symptoms, as well as being used as a metric in response to treatment over time. One example of a rating scale is the ADHD rating scale. And you see it here on your screen. It's a simple 2-page rating scale form that's in the public domain, that's easily scorable, and it takes about less than 5 minutes to complete. And another commonly used rating scale is the Vanderbilt rating scale as well, which is also in the public domain. Please remember, these rating scales do not make the diagnosis of the disorder. These rating scales aid in the assessment of the severity of the symptom. They aid in establishing that baseline prior to the initiation of treatment, and they aid in the measuring of the response of treatment over time. Next question, true or false? Psychological testing is part of the routine workup for the evaluations of persons with uncomplicated ADHD. And the answer is false. So if you look at established practice guidelines, the diagnosis of ADHD is a primarily clinical diagnosis. As you heard, it's generally diagnosed through a very careful history and a detailed history obtained from multiple informants if possible, and hopefully utilizing these dimensionally based rating scales to help quantify some of the symptoms as well. Psychological testing or neuropsychological testing is not considered medically necessary for the clinical evaluation of children with uncomplicated cases of ADHD. And the emphasis is on uncomplicated. If there is the differential diagnosis includes a learning disorder or any other disorder that may complicate the clinical presentations, then sometimes psychological testing is indicated. Addressing the use of, and there's insufficient data for the use of these other methods to help establish the diagnosis of ADHD. There may be individuals who utilize these methods, but these are not currently considered evidence-based practices in the establishment of the diagnosis and or treatment response. Now we're going to proceed to the actual ADHD criteria for children and adolescents 17 years and younger, and this is the Bsn5 criteria. Very few people by no means memorize all of the criteria, hence the importance of really having either validated rating scales or having access to the actual criteria when you are performing your diagnostic evaluation, lest one falls into the predicament of making a diagnosis and or initiating treatment on just an impression of a few symptoms and saying, aha, this is what you have, and then the train's left the station. As you know, ADHD presents with two core domains. One is inattention, and the other is the hyperactive and impulsive domain. Here on your screen, you could see your typical ADHD symptoms that have to be present for at least a period of 6 months, and to meet the symptom threshold criteria, 6 out of these 9 need to be present. And as you'll see again in a second, we will emphasize about that these symptoms should be cross-situational. They should be observed and creating impairment in more than one setting. The second big cluster, a big domain, is the hyperactive impulsive cluster. Similar criteria thresholds that the symptoms need to be present for at least a period of 6 months, and that there should be at least 6 out of the 9 present for endorsement of meeting the diagnostic threshold as well. Once the child has presented, once you have obtained the information from the parent, guardian, as well as hopefully school, tutor, and any other caregivers involved, whether that's a grandparent or et cetera, tutors are sometimes involved. Once the child has been interviewed, once you have completed your diagnostic assessment and confirmed your diagnosis, then you proceed on to your treatment plan. And the treatment of ADHD is multidimensional, and clinicians should always provide psychoeducation about the ADHD to the family, or just have those discussions with the family, including the clearly defined treatment expectations of what should improve, what are the domains that are going to be the focus of each of the interventions that they will be implementing. In addition, that there should be frank discussions with the family members and engaging them actively in treatment and determining their treatment preferences. There will be many family members who present actively seeking medications and not wishing other interventions. There'll be many family members that actively avoiding medications and actually maybe even avoiding obtaining care because for fear of their children being put on medications. And you want to, as a way of engagement, and really get a good assessment of their expectations and help guide that in your comprehensive treatment plan. One of the things we know is that there are over 24 elegant randomized controlled trials that have demonstrated the efficacy of behavioral interventions in helping children and adolescents with ADHD. So that interventions such as parental management training, or skills training, or contingency-based behavioral interventions, both at home and at school, are a first line of intervention. There is some literature that does support that tiering is an important variable. That is, that if one initiates medications before initiating behavioral interventions, there are shorter, more immediate gains, but over time, those seem to separate or be less than the behavioral interventions, and vice versa, that if one intervenes with behavioral interventions initially, and then if needed, medications are added as part of the treatment interventions, that the gains are more sustained over time, albeit sometimes even slower. Needless to say, that depends on a variety of different variables, including the severity of the symptoms and presentations, because we've all seen examples of 6-year-olds with very, very severe symptoms and with a lot of impairment in impulsive and high-risk behaviors, where the ability to initiate a good 12-week trial of behavioral intervention before assessing the need for medications is maybe either not appropriate or will not meet the child's needs. So in addition to the behavioral interventions, other interventions include the skills building, which some individuals call either executive function training or organizational skills training, or study skills development, etc., as well as appropriate educational interventions. A note on teenagers. Teenagers, we know, are a special and unique population in general, but teenagers with ADHD create other challenges because traditional contingency-based behavioral interventions are much more of a challenge, and frequently interventions such as motivational interviewing in combination with the behavioral interventions and or medications is required. So especially the MI, the motivational interviewing, to get the teens to see the benefits, hopefully, and engage in the process and move that dial of improving their functioning and hopefully decreasing the impact of these symptoms. So as you've heard, after you perform your full diagnostic evaluation, after you've confirmed your diagnosis, you generate your treatment plan, which you've heard includes your behavioral interventions, your skills building. Remember, skills are tools, right? So it isn't the what one needs to do, it's how you're going to do it. And we know that very well, for example, from the weight loss literature. We all know what we should be doing regarding exercise, eating, sleep, etc. But the actual implementation of how to do it and the actual execution of that is what the great challenge is. So it's that development of those tools as the child is hopefully becomes older and they're able to internalize them, that leads to the continued maintenance and success over time, not just in school, but in other of life's domains as well. And if you get to the point where medications are being considered, once again, there should be a frank discussion with the family as to their treatment preferences. There are family members who present who agree to medications, but are very adamant on either one or the other class of medication, or some that are specifically say, I do not want my child on a stimulant. I want to look at other options. And then you have your frank discussion, which we'll get to in a second. As you're having that discussion, one should also be defining with the family and with the teenagers, if they're older teenagers, the target symptoms that one expects to improve with medications. What does that mean? That means that medications such as psychostimulant medications, we would not expect to have a direct effect on the ability to plan, to organize, and some of those executive functions, to prioritize, etc. But we would expect that to help other target symptoms or behaviors, such as the ability to initiate a task, the ability to maintain or sustain attention on that task for a more developmentally appropriate amount of time for that the complexity of the task, and obviously their developmental age. The ability to filter distractions in their environment and continue that work, and obviously things like mental energy and mental stamina over time. The rating scales that we had discussed earlier, whether it be the ADHD rating scale or the Vanderbilt rating scale, to mention a couple in the public domain, are very good at helping quantify the severity of those behaviors and helping measure, and they will help the practitioner measure response over longitudinally as well. Please remember that the practice guidelines address appropriate safety assessments at each of the visits, which include your vital signs as well as your height and weight. And we can address that more a little bit afterwards as well. So as you all are probably familiar with, there's two large groups of medications utilized to treat attention deficit hyperactivity disorder. The first group are the stimulants, which are usually considered the first line or the first choice medications for this disorder. And that's because the studies have demonstrated that they're the most efficacious. But there's a little asterisk there now in a second. As you know, the stimulants are now controlled substances, and they fall into two large groups, your methylphenidate-based group and your amphetamine-based group. Beginning July 1, a side note, any youngster 16 years old and 17 years old, you will be required to have the mandatory consultation through eForce when those prescriptions are written. So when HB 21, House Bill 21 goes into effect July 1, although it excludes technically children, the 16 and 17-year-olds are included within that bill, and therefore you will be required to check that. I personally have already begun informing parents that whereas prior to this, the minors were not included in the PDMP in that database, but now beginning July 1, they will. And then the non-stimulant medications for ADHD include your alpha-2 agonists, such as clonidine and guanfacine, and atomoxetine, which is sold commercially sometimes as Strattera. These medications are not controlled substances. They work a little bit differently than the stimulants, needless to say. They take a longer time to reach their maximum effect, and recognizing that only the extended release forms of the alpha-2 agonists, that is the guanfacine extended release and the clonidine extended release, are FDA approved for this indication. We mentioned that stimulants are usually the first line medication, but as you'll see in a second, with the emergence of the latest round of clinical data, that these extended release alpha-2 agonists now are considered to be on par as far as first line medications for ADHD. This level system is derived from all the large work done from Florida Medicaid Mental Health.org, where the decision making and the recommendations are tiered into levels, with level 1 having the highest level of scientific evidence supporting it. So for example, decisions were made based on the more randomized controlled trials or large meta-analysis are considered high level of scientific data, whereas a single case report or clinical consensus is considered a low level of scientific data. So any of these recommendations that you'll see on level 1 are considered strong, scientifically supported recommendations on the use of these interventions. So in reviewing all the large body of scientific literature that exists for the medication treatment of attention deficit hyperactivity disorder, the use of a stimulant or an alpha-2 agonist extended release form is considered first line recommendations. That's a change from the previous iteration 2 years ago, where the alpha-2 agonist, the evidence base was a little bit less robust. But over the last couple of years, there has been sufficient information and evidence to support their use almost on par with the stimulants. Keeping in mind that, so recommendation is, you see the child, they have ADHD, a decision is made to initiate treatment with medication, you will start monotherapy with, take your pick, a psychostimulant. And you can take your choice. There is no data that specifically points to one stimulant is particularly better as a class than the another. And you'll see in a second, it could be a parental preference, it could be duration of action, etc. And the same thing for the alpha-2 agonist, whether you decide a guanfacine extended release preparation or a clonidine extended release preparation. One of the ways that practitioners decide which medication to utilize is what time of the day the impairment's happening. So if one looks at across the day, there is the preschool hours, there are the school hours, the after school hours, and then evening hours. And so although by far the majority of the impairment happens during the school hours and the after school hours, there are a small group of kids who display a fairly severe symptoms and impairment in the early morning before school and certainly in the evenings. And this graph, what it does is illustrate some of the more typical stimulants and their duration of effect. We take our desired coverage of the medication, where after the detailed history has determined that where the problems are occurring predominantly, and then you try to make an informed decision as to which medication will hopefully provide the biggest improvement during that time period throughout the morning. Needless to say, none of these medications, unless you are taken very, very early or even before awakening, are going to help prior to breakfast. Because I have had some very severe kids with very severe presentations where we have provided the medications to the kids while they were sleeping, about a half hour to an hour before the parent would wake them up, they would go back to sleep, and then when they awoke, they would be much more linear and less impulsive and more getting ready and off to school. And that's not to say there was a host of other issues with that, including potential side effects. You make your choice of your medication based on on a variety of different factors, of which one of them is length or duration of action. Proceeding on, if you want to initiate treatment with one stimulant, and one goes titrating the dose up slowly until either there's satisfactory improvement in the target symptoms. Remember, you've defined those target symptoms up front before you've initiated treatment, or treatment limiting side effects emerge, and and that intolerance does not allow continuation of either the medication or further titration, or you have a suboptimal dose, so therefore you have to stop it, right? And so if you pick one and it's either ineffective or there are treatment limiting side effects, then you switch to monotherapy with another stimulant or another or an alpha-2 agonist. So although it says another stimulant, it could be if you started an alpha-2 agonist, you could switch to a stimulant. If you started one stimulant, you could switch to another iteration of a second stimulant, or you could switch to another iteration of monotherapy with an alpha-2 agonist. We also know that Sometimes, as you saw, depending on the duration of the action, if there's a need to supplement the longer acting extended release preparations of stimulants with immediate release stimulant, that we want to stay within the same class, i.e. that if you have initiated treatment with a medication such as methylphenidate extended release, and you're seeing that there's a need to supplement a dose later in the afternoon, you want to supplement that with an immediate release preparation of methylphenidate and not combine it with an amphetamine-based preparation. No, no, no. The alpha-2 agonists, as you saw, are very effective for ADHD. They typically take about 2, 3, 4 weeks to reach the maximum preparation. They must be taken daily for them to work, in contrast to the stimulants. And as you all know, the side effects are different, of which not one of the not, or the sometimes more appealing to certain children and or parents is the lesser effect on appetite compared to the stimulants. If one has tried one treatment with a stimulant or an alpha-2 agonist, extended release medication, the child hasn't responded adequately, you switch to monotherapy with one of the others, you've titrated the dose up, and again, you haven't gotten adequate response, then we move on. And if you've had a partial response to the monotherapy, that is, if you've started a stimulant and a second stimulant and you think that you've got somewhat of a response, but not what you would define as an optimal response, then at this point is where you consider combination therapy. Up until this point, it's been monotherapy. So at this point, if you're on a stimulant, then you look at augmentation or combination treatment with an alpha-2 agonist, extended release preparation, because that's where the body of evidence supports. There are some individuals that will utilize the immediate release alpha-2 agonist, but by far the literature supports the extended release. Or one then moves on, instead of using combination therapy, there's an equal amount of literature supporting the use of atomoxetine, in the sense of how efficacious or how helpful it is at this level. Atomoxetine is another non-stimulant medication that obviously must be taken daily. Differs from the alpha-2 agonist in its mechanism of action and how it works. In a lot of ways, structurally, it's more similar to an antidepressant, hence why it has the same FDA warning on the emergence of suicidal thinking and behavior that is imposed by the FDA. The side effects are also different from the other non-stimulants, from the alpha-2 agonists, and including the need to kind of check your liver enzymes on both at baseline and periodically, due to the possibility of some benign increase in liver enzymes. And then we move on to level 3. And so you've initiated treatment monotherapy with a stimulant. You've moved on to a monotherapy with a second stimulant or an alpha-2 agonist. You moved on and you say, no, we're going to use combination. We have had a partial response to my stimulant. I'm going to use combination treatment. Or no, I haven't had success with any of those. I'm going to initiate treatment with atomoxetine. And then you've said, gee, my responses have not been robust. Well, then we're getting into where our evidence base becomes less and less clear. But at this point is where there is enough evidence to recommend the initiation of treatment with an immediate release alpha-2 agonist. The evidence base is less strong, obviously, as our first level 1 medications. So they could either be initiated as monotherapy or in combination with any of your other ADHD medications. It just becomes less clear. You'd be going further down into the weeds by now. And then, needless to say, level 4, it's time to stop and take a step back, because you've already tried 1, 2, 3 different levels of medications, and it's much, much more prudent to take a step back and look at diagnostically if there are the presence of any comorbidities that are complicated the picture, or to really reassess if this is true ADHD, and that although it may appear to be, but maybe there is some other explication as to the symptoms. In addition, at this point is where we introduce medications such as bupropion, sometimes sold commercially as Wellbutrin, or any of the older tricyclic antidepressants. And these are included down here at level 4 because there is a small body of evidence supporting their use, but it's not very robust, and it's limited. So if you're already down at this level, you really, really should be careful in how you proceed. Clinical pearl, you've heard it. After treatment failure with 3 medications, you should really have a diagnostic reassessment, or say, wait a minute, maybe it's time to consult a specialist, or so that we can get another pair of eyes and ears to either see if there's something missing diagnostically, or if there's some other way of how to proceed with treatment with medications. Big table with little fonts addressing all the medications that are available. And I believe there's one more that came on the market just recently. There's now a methylphenidate ER 72 milligram tablet presentation, but that they're all basically variants of the same class, and with different routes of absorption, for example, going from capsules to tablets to a patch to liquid to the ODT is the orally dissolving tablet, where it's put on the tongue and it dissolves, etc. So there's a lot of different medications. Your formularies will be a guide as to which ones you can utilize, but it's really similar molecules, just different presentations that will hopefully help in either producing that clinical benefit or the tolerance to the medications. Here as well, you'll see this is your non-stimulant medications that are here on the market, with the ones that are FDA approved. And then another clinical pearl, that response to stimulant medication does not equal the diagnosis of ADHD, where there's individuals that say, I'm not sure, but here, let's try this. And if the individual improves, we go, hence, therefore, that child has ADHD, and that's just not true. So that just a mere response to stimulant medications does not equal the fact that one has ADHD. Couple words of cautions, right, is that we do not recommend the combination of 2 different alpha-2 agonists in the treatment of ADHD. That is, you don't want to combine a clonidine-based preparation with a guanfacine-based preparation, and that the use of antipsychotics as either sedatives or to help for sleep or to treat the core symptoms of ADHD is not recommended. The bottom line here is your cheat sheet on your medication recommendations by level, what we just went over, and that hopefully this provides a guide. It becomes a little bit more complicated when there's other or multiple comorbidities present. We do recognize that, but this is an attempt to provide evidence-based guidance to the decision-making that will hopefully lead to better outcomes and appropriate medication use for children with ADHD. In closing, and just a couple of takeaway points. One is rating scales are extremely useful for helping support the diagnosis, obtaining your baseline, and guiding treatment. Always utilize your behavioral intervention, your executive function and organizational skills, and then try to follow your evidence-based guide for the use of medications. And on that note, my portion, I will turn it over. Thank you.
It never stops me amazing to listen to your lecture, sir. I always come home with a couple of pointers. And now I should say welcome to our world, that is a busy pediatric office in a suburban setting. My narrative is very well defined. That is the pediatrician's perspective of what we perceive Could be actual barriers or a perception of the barrier in accessing the behavioral health resources. To understand what we do, it's important for the audience to know where we are and what we are comprised of. Ours is a pediatric group practice comprising of 5 pediatric providers, 3 physicians, and 2 mid-level providers. And our patient population is 90% of them have got the Medicaid as a primary insurance. The remaining rest of them could be self-pay or private insurances. I'm sure that by this time, some of you already are trying to identify with this practice, and more interesting is coming. It's we have about 40% Hispanic population, and when we looked at the data, this last Thursday, 10 to 12% of our patient population have got one or the other type of the behavioral health issue billed as coding. So that's how we could come up with this figure, 10 to 12% of our total active populations. What that means is if our providers see about 20 to 25 patients per day, and in any given day we have 3 full-time practitioners, that means we'll be seeing 6 to 10 pediatric patients with behavioral health issues. We see children from 0 to 18 years. Among that population, what we have, pediatric population with the behavioral health issues we have, 2 to 5 years, we have about 4% of them. And between 6 to 10 years old, we have 15% of the patients of them. And more than 11, that 11 till 18, we have 21% of the patient population have been assigned one or the other diagnosis. So why it is important? Because when you are working in a community setup, even though the 4% of the population that age 2 to 5 have got the behavioral health concerns, they are the parents coming and addressing, and who takes time to address where we are going with the issues what they are bringing. And fortunately, during the process of being recognized as the patient-centric medical home care, it is a requirement that we have to enlist all the resources. And so during that process, we contacted most of the psychiatrists in our area, and we have the business associate agreement with them. So that helped us. And so this is the bird's eye view of what we are and where we are. And the barriers, what we feel as the barriers here is training, time, tools, and the support. When I say training or the lack of it, when we started the pediatric practice about 28, 30 years ago, ADHD was a buzzword. During the conversations, parents will just drop that word here and there. My child is inattentive or not able to complete the tasks. And it was maybe 1 a week. But now we are seeing 6 to 10 every single day. And were we trained sufficiently during our residency programs? I'm sure much younger doctors than me that will be able to vouch for that. Still, it is not up to par. And we are educating ourselves by listening to Dr. Castellanos, like highly specialist individuals, and by attending seminars. And the time, once again, or the lack of it, we all know that empathy is the cornerstone in getting the trust of the parents that we are with them and we can do together, help the family. And we need to learn to manage the expectations of the parents. To do this, we need time, and how much we have and how often we have, I'm sure we all know that. And the tools, thanks to the internet, we have widely available mental health screening tools available, which we utilize in our day-to-day practice. However, having said that, even when we administer these health screening tools, in order to understand the culture-specific barriers so that we can address them effectively, most of our Hispanic population, they request verbal administration once again. Even though we give them the Spanish pamphlets, they would like us to administer them verbally too. There goes our 1, sometimes 2 employees timing. So how do you allocate the time for that? And at the end of the session, if any of the audience are interested, they can get this pediatric symptom checklist, and I shall tell you where to get those checklists, 17, 35, and pictorial pediatric symptom checklist, that's 25, and strength and difficulties 25Q. And as Dr. Castellanos said about Connors and Vanderbilt, all are available, but how much time can we allocate to administer, evaluate, treat, follow up? That comes to support system what we have as a private pediatrician. As I mentioned, that we are in a way blessed to have our patient population having some kind of health insurance, because that is considered as the main barrier in the adult healthcare when they're trying to provide the mental health issues, because finances. Here, our pediatric patient population in our setup, most of them do have some sort of an health insurance. And medical managed care are doing a pretty good job in providing us the panels, but when we need how often to get it, that's we'll come to that. And the referral sources like a psychiatrist. And we did a small project for this webinar. From our office, we called psychiatrists around for a real patient, one as a mother, another one as from an office employee calling that Dr. Lokesh wants. This child definitely needs to be seen. How soon can you provide an appointment for this particular patient? The results were surprising to us. That does not matter whether the mother called or our office called. The nearest available appointment was 3 to 4 months out. And one particular incident, it's a referral center quite nearby to us. It's booked till February of 2019, and we should contact them later. So where do we go under these kind of circumstances? That's when I got excited when while we were attending the integration of the behavioral health as a primary care in the primary care pediatrics. When I was there in Orlando, when I came across this state officials talking about telehealth, I said, could this be a new window for the primary care people that we can obtain the consultation with, such as Dr. Castellanos for that matter. He's in Miami. So I could obtain his, I can pick at his knowledge and get some help, that much needed help for us with the complex patients. So that's when I thought, okay, there is an opening. And still, I'm not one of those, our office is not one of those 15% of the self-recognized telehealth practitioners as per the AAP report. That's 2017 report. We very much would like to, we are exploring the possibility of participating actively. Does it mean that we have no concerns about telehealth? Well, we do. That's where I'll be asking question to Anna myself, that how would I address these concerns if I'd like to participate in the telehealth, like potential liability issues, that inability to for the reimbursements, and the technical issues. Having said that, I definitely see that there is some kind of a light at the end of the tunnel, and I sincerely hope it's not the oncoming train. Having said that, I would like to have more time for the discussion. So I think this is what we are, and next speaker, probably we should start the presentation. Thank you.
Good afternoon. I am the CEO of Empower, and we are a nonprofit located actually in the Central Florida area. But as you'll hear, we do services statewide through telehealth, telepsychiatry. I am not a clinician, so I'll start by saying that, and I'm very honored to be presenting with these two doctors. Just a little bit, and I can talk through this pretty quickly, but we realized most of our services are outpatient, well, all of our services for psychiatric are outpatient and either psychiatrist or therapy. And what I found when I started here 10 years ago is that even though we have our own psychiatrists that work for us, is that there's a severe shortage, and I couldn't get doctors, as you just heard, to treat our clients, even in Brevard County, which is really only an hour away from us, and I wouldn't consider that a very rural community. But this is one of my favorite slides. If you look at the second bullet, data shows that there's an average needed of about almost 26 psychiatrists per 100,000 people nationwide. The national average is 10 per 100,000. Florida has only 7 per 100,000. And if we narrow that down to child psychiatrists, there are only 4. And the average age of our psychiatrists are over 55. That's what really put me into action, saying that we needed some other solution. And for us, telehealth was that solution. We have been doing telehealth for psychiatry and therapy since March 29th of 2013. This was our first client. To date, we've done over 130,000 telehealth services. We do now about 800 a week. We have about 50 practitioners, which is a combination of therapists, psychiatrists, ARNPs, PAs, you name it. And we're working on a virtual treatment team as well. What we do, I always like to tell this story, telehealth is not a service. A lot of folks kind of start wondering, oh, this is something different. I always tell this story. My dad would be 104 this year if he were still alive, and his doctor came to treat my grandfather and he on a horse. We have since kind of evolved to where we are now, and now the practitioners coming back to your home, but on a smart device. So everything that we would do in a traditional face-to-face setting, we do also via telehealth. It's just the mechanism on which we can get that treatment to the client. Our sole source is to eliminate the wait list that you just heard about, get quality care quickly to clients that are in need, and there's just a shortage, and there was really no other way for us to do this. Our platform is HIPAA compliant platform as well, and the beauty of it, it was designed for us. We do a lot of child welfare work as well, but we have a multi-participant platform, so we can have 6 to 10 folks on a session at one time. This helps us, as you just heard, if we need the pediatrician in to consult at the same time with our psychiatrist or practitioner. In the child welfare system, if there's a guardian ad litem or a case manager or anybody else that needs to be involved in that session, they can be, and they don't have to leave where they are. For us, and what was really a game changer for us is all of the Medicaid, the Florida Medicaid plans do cover telehealth. And I never thought I'd say this, but Medicaid in the state of Florida is way ahead of private insurance. Right now, private insurance does not cover telehealth unless you have a kind of a self-insured plan, and when they do that, it's with a teledoc or something. It's not your own practitioner. It is somebody else that you can access through those platforms. We started by doing what's called a hub and spoke, which meant our practitioners had to be in our office and a client had to be in an established spoke site, like another doctor's office or a school or a domestic violence shelter, somewhere that we had formally set up. Medicaid has since changed that rule, and you can do direct to consumer, which means our practitioner can be anywhere and the client can be anywhere, obviously in a HIPAA compliant place. So now we've also looked at our practice, and the light bulb went out with us. Most of our clients are Medicaid at this point, although we do take other forms of payment. But we've changed our clinic hours, particularly for psychiatric. We're open Monday through Friday, 8 to 8 p.m., and Saturday hours as well. And in September, we literally closed all of our physical offices. We are 100% a virtual practice right now, other than when we go into the schools or there is some community work that we do. But very little of our work is done traditionally face-to-face. The equipment is needed is very easy, particularly for psychiatric. There's no special devices that we need to use. So the individual just needs a smartphone or a tablet, a PC Mac with a camera and an internet connection. And believe it or not, in the Medicaid population, it's been proven by us and by others that the majority of the folks do have access to a smartphone, and that's where the majority of our services are conducted. We still do spoke sites in the community where folks may congregate, homeless centers, doctors' offices, wherever, churches, but most people are seen on their own smart device. We also paved the way here is a big question I get. When Medicaid allowed telehealth to be done, at the same time, the Florida Board of Medicine enacted a rule in reaction to the pill mills that prohibited the prescribing of prescribing of controlled substances through telehealth for an outpatient setting. Unfortunately, there are no psychiatrists, or there weren't at the time, on the Board of Medicine, so we actually petitioned and were granted a waiver. So for a year, we were the only entity in the state that could actually provide or prescribe controlled substances via telehealth. At the same time, the board asked us to do an outcome study for that first year, which we did, and our outcomes were here. We found that our clients were more likely to seek treatment. Obviously, it's much more convenient. They were more likely to stay in treatment. Most of our, if not all of them, were satisfied. And my favorite is 10% fewer prescriptions were actually prescribed via the telehealth group than face-to-face. So that was huge for us as well. We also did a similar study at the University of North Florida, same type of outcomes. It did show that the quality, it was no different between the traditional face-to-face as well as the telehealth. What we've been able to do is reduce our wait time. You just heard Dr. Lokesh mention this. Our wait time before we did telehealth for a psychiatric appointment was anywhere from 3 weeks to 6 months. We can now see clients within 2 to 4 days, and if it's an emergency situation, we can often get them in that day. Our no-show actually went down from when we were in the clinic, our no-show rate went down from over 60% to 12% as I am here today. We do all prescriptions via telehealth. We did get that law changed. It is now you can prescribe controlled substances that are non-narcotic via telehealth for the treatment of behavioral health disorders. So that has now been changed for the Department of Medicine. Our prescriptions are all done electronically. We have no paper anymore, and our doctors are able to see where other clients are going. We've stopped a lot of pill shopping from that. We do have some cooperating pharmacies that will deliver the prescriptions to the client's home within 24 hours. Again, to us, it's all about access of care. A lot of individuals worry about the biometrics. I heard both doctors speak about that. We have an arrangement with the Higgy machines in Publix. Many of you probably have gone to get your blood pressure taken, but you can start your own account, and at night those results, as long as the client gives us access, are uploaded to our electronic health records. So we ask the client to go 1 or 2 days before their appointments in order to do that, or we can get information from their pediatrician, or they can go to a health department. We try to give them as many options as possible. It's very easy to get an appointment with us. This is our website. You go to www.empowerfl.org. You can refer yourself or your child. Our whole process is electronic. There's no paper that is attached, and then you will be MEND is the platform that we use. It's a very HIPAA compliant. It's a very simple system to use. I'm not going to go into it, but we have folks that also will help the patient practice beforehand and make sure their computer and their equipment is set up. So I tried to leave enough room for questions. I went through that pretty fast, but I am a firm believer in telehealth and telepsychiatry, and I've just seen the amount of change. The other thing that I mentioned was that once you have a practitioner, you don't have to change if you move, as long as the practitioner is licensed in the state of Florida, and the client's in the state of Florida. You can keep the same practitioner throughout your treatment. So with that, I'll turn it over for questions.
Well, thanks to all of our panelists. I think that was a very informative and good presentation. I want to reiterate a couple of things. One is doing the work in this field with children with mental illness problems. One of the things that I've discovered in my work as a child psychiatrist is the difficulty with identifying, because the prevalence is very high, and the number of children that are identified and taken into active treatment is low, and often we wait too long. We wait until they've already repeated a year in school, and I think of repeating a year in school as a waste of $8,000 or $10,000 beginning depending on which school district that you're in. So let me just go ahead and take this first question, which was about the various checklist forms when you're working in behavioral pediatrics. And what I would do there, the the person who asked the question said, well, they usually just tell me online. So I'm going to tell you where they are online. So what you want to do is you want to go to medicaidmentalhealth.org, and there are links there to a wide variety of resources that will help you in your work with children who have behavioral health problems, and it covers the whole gamut. There is a group in Florida, child psychiatrists. We meet every 2 years, and we regularly update some guidelines on evaluating, treating, both from a counseling and therapy point of view, as well as looking at medications. The presentations that we listen to often are recorded and are available for you to listen and to get information that way, as well as the different diagnoses are covered in detail with clear connections and links to the particular forms that are used. The Vanderbilts are what I use in my own practice as a child psychiatrist. They have parent rating scales, teacher rating scales, and there also are follow-up scales with the Vanderbilts. So I would encourage people who are looking to improve the quality of their assessments to look to that resource. It's medicaidmentalhealth.org, but it's sponsored at the Florida Mental Health Institute, University of South Florida. Dan, if I can get you back on the line, the next question is questioning the prohibition. You spoke strongly about the caution about using Seroquel for sleep, and a specific question about using Abilify or aripiprazole for hyperactivity and irritability. So Dan, I'm going to let you take that one.
Sure. Actually, when you talk about quetiapine specifically, when we looked at all the evidence base, and when you look at the evidence base for insomnia in general, there are no studies demonstrating that quetiapine is beneficial for sleep or insomnia in children and adolescents. And in general, one of the reasons why we do not recommend them, because but whether it's quetiapine or aripiprazole, et cetera, because we're talking about, first of all, we don't use it for the core symptoms of ADHD. And then secondly, when you talk about some of these secondary issues, there are other medications that have a more benign risk or side effect profile. And it really is that side effect profile that brings the area of concern longitudinally. So if you talk about sleep, the literature supports melatonin. That's where by far the most robust information is on melatonin. And we're actually going to talk about melatonin at next week's presentation on neurodevelopmental disorders and sleep, which is a big one. And then secondly, even though it's also less robust, is the use of clonidine for the sleep in kids with ADHD. When you talk addressing the irritability and some of those issues, if it's hyperactivity, that's considered one of the core symptoms. And again, the antipsychotics don't have a specific place for the core symptoms. The irritability is a different issue, and that would be one that I'm not clear exactly what that is or what that would be, and whether it's medication related, whether it's comorbid, some other comorbid disorder, so it's a little bit less clear. But in general, it's the concern about the metabolic side effects with extended use of all of the antipsychotic medications. Dr. Benson?
Yeah, so if I could speak just to my child psychiatry practice, I see many children who are referred in where they have been treated with Seroquel or Abilify. When I'm able to take the time to do a more in-depth evaluation, what you find is that the family has overlooked some very important behavioral interventions that can help with sleep problems, help with the hyperactivity and irritability. What I tell people is that almost everybody has more confidence in my medicines than I do. And I like to brag that I take children off medicine about as often as I put them on medicine. Like we've gotten way over reaching for our prescription pad instead of looking to find the time to really address. I want to give there are two questions that I'd like to turn over to Anna. One was about the getting the patient referred to the Empower service, and the next is any online resources on telehealth and telepsychiatry.
Sure. The way to refer to us is go to our website, which is www.empowerfl.org. It's Empower with an I. There are two large buttons that say refer yourself or refer someone else, and you just click those and it'll take you right through it. The online information about telehealth, there's American Telehealth Association, which is a national group, and anything you want to know about national outcomes, Florida is actually behind other states in the implementation of telehealth, but it has been used for years with veterans, in the military, so it's not actually a new practice. It's been around, but we're just getting into it and getting it allowed here in Florida.
If I could add, both of the American Academy of Child and Adolescent Psychiatry has a guideline on the use of telepsychiatry with children. It's published in 2017, and it's available if you go to www.aacap.org and look for practice guidelines. And the American Psychiatric Association has a whole section on their webpage about telepsychiatry. The psychiatrists have heard about the problems with getting access. We've got to do something to address that, and I think this is certainly a step forward. Dan, I'm going to give you this last question. I think we're about out of time. What's the minimum age to start a stimulant because we're seeing younger and younger children with symptoms?
There is no minimum age, but we do know that the younger the child, the less likely medications are going to be utilized. Not having said that, there are some a very small, very select cohort of kids that are 4 years old that are extremely severe in their presentations that sometimes we utilize medications. The guidelines that we discussed were kids 6 to 17 years old. It's a little bit different in the preschool age, right? Where stimulants are the first line. And so even though, and they're at the MedicaidMentalHealth.org as well for that preschool age. So there is no minimum age. It's just that the younger the child, further down, the less likely. And the more likely we look for other causes as well. So that 5 years old, 4 years old, we do know that any of the kids in the state that are receiving Medicaid and are being prescribed medications for that young, that's an automatic referral to get reviewed as well. So I refer you to the guidelines online because of time to look at MedicaidMentalHealth.org and under the ADHD section and under the preschool section where it addresses some of the safety issues and the medication recommendations are much more finite because of the little bit more limited literature that exists in this age group. Dr. Benson.
I want to thank everyone for joining us today. I hope this information has been helpful. We'll look forward to having you join us. I think Dan and I both are going to be on the conference next week. We'll be able to continue this discussion and look forward to being with you again soon.